Hi students, after completing the discussion on the purely sensory and the purely motor nerves, with the exception of the accessory nerve, which is the purely motor also, but in our classification we have kept it outside those three groups, purely motor, purely sensory and the mixed nerves. We have kept this nerve deliberately out of this circle, because this is an additional nerve, an accessory nerve that will come to help to carry some of the fibers. You see this voluntary fibers of the vagus nerve for some period, you see that for some short distance, carrying these fibers, and will hand over these fibers safely here to the owner, that is the vagus nerve. But after that, you see, after these purely sensory nerves and the purely motor nerves, we are going to pick up here the mixed nerves now. And in these mixed nerves, you know that if you want to remember the mixed nerve, for example, recall the mixed nerves, which will be the mixed nerves, like which are the purely sensory nerves. You see that those are those nerves which subserve the special senses, special somatic afferent senses. You see that special senses with the exception of the taste. And you have already seen here smell, olfaction, olfactory, vision, optic. Here this will be seen the ear, that is the vestibular, and the cochlear, so the eighth nerve. So the first nerve, olfactory nerve, the visual, that is called here the optic nerve, and the vestibulocochlear nerve. These are the purely sensory nerves. And if you want to recall the motor nerves here, motor nerves are those nerves which supply, which innervate the highly skilled muscles, which in fact supply the highly skilled organs here, well controlled organs here on your face. And one of them, you see, it is the tongue, another is the eyeball. Eyeball means extraocular muscles, those nerves which supply extraocular muscles, three nerves. The third, that is called the oculomotor. Fourth is called the trochlear, and the sixth is the abducens. And then is the tongue, which is in fact a very, highly controlled organ that can convert the voice into speech, make the words highly articulating. And you need here again a purely motor nerve, that is called the hypoglossal nerve. So these are the four purely motor nerves which you can recall. They have the commonness, means they have to supply those organs which are under high control, you can say. And now as far the mixed nerves are concerned, if you want to recall these mixed nerves, you see that you can recall them. They are doing a lot of functions, but if you see that one function only which will remind you of these nerves, the numbers of these nerves, you can actually recall them. These are those nerves which will supply those skeletal muscles on your face, which develop from mesenchyme, which develop from pharyngeal arches. All of these nerves which will supply the pharyngeal arch muscles, they must be mixed nerves, because they are also supplying many other things. And out of this, you see that you have got 5 pharyngeal arches in the human being, and these 5 pharyngeal arches are giving rise to 5 groups of muscles, but these 5 groups of muscles are supplied here by 4 nerves, because the last 2 groups are the last 2 pharyngeal arches, 4th and 6th, because 5th is not there. So 4th and 6th, they are supplied by the vagus nerve, the same nerve, through different branches. The remaining 3, 1, 2 and 3, they are supplied here by the 3 nerves. And out of these 3 nerves, the first one, muscles of mastication, developing from first pharyngeal arch, they are supplied here by the trigeminal nerve, the mandibular division of the trigeminal. So you can say trigeminal nerve. So trigeminal should be the mixed nerve. First mixed nerve among the cranial nerves will be the trigeminal nerve, because why it is the top nerve? Because it supplies the first pharyngeal arch, the muscles of the first pharyngeal arch. As far as the muscle of second pharyngeal arch are concerned, again you see that it is the facial muscles, so it should be the facial nerve. And when you are going here to the next single muscle from the third pharyngeal arch, stylopharyngeus, glossopharyngeal nerve, all these are the mixed nerves. And then you will go to the 4th and 6th pharyngeal and laryngeal muscle groups. You see nerve will be the last mixed nerve, that is the vagus nerve. So the nerve which you are going to discuss here is the trigeminal nerve, and trigeminal nerve, you know, that is the 5th nerve. So that means your mixed nerves start from the cranial nerve number 5, fifth cranial nerve is the first mixed nerve, because about that you already know. About that from midbrain emerge two nerves here, the third and fourth, both purely motor. And still above that from the forebrain emerge two more nerves here, first and second, olfactory and optic, purely sensory. So first two nerves are purely sensory, next two nerves are purely motor, not mixed yet, so the fifth should be the mixed. Now the fifth should be the mixed here, means after those four nerves we have got 8, and out of this 8, 4 from pons, 4 from midbrain. I say 4 from pons, 4 from medulla oblongata. And out of this nerve, because this is actually from the, so you can divide them into the 4, 4 and 4. The first 4, the 2 from forebrain, 2 from midbrain. The first 2 from forebrain, both purely sensory, olfactory and optic. Next 2 from midbrain, both purely motor, oculomotor and trochlear. And next 8 now out of this, the 4 from pons and 4 from medulla oblongata. Among them obviously there will be some mixed and some purely sensory and some motor also, but they are 4, 4 now. Out of those 4, the fifth in fact will be from the upper pons here. Upper pons, this is the mixed nerve which has the sensory root as well as motor root. This is the trigeminal nerve. We call this is the fifth nerve. You see that the fifth, you can write the fifth as a V. This is fifth. Fifth, you can draw 3 points from this V. 3 points. Out of these 2 points in fact are in one direction, and the third point is in another direction. 2 nerves, third nerve. It has 3 divisions. That's why we call them trigeminal. Trigeminal, fifth nerve, 3 points of the trigemina, 3-headed nerve. And out of this trigeminal, 2 nerves have the same direction because both of them are purely sensory divisions. This is also purely sensory division. But the one who is actually the one which has the direction on the different, you say, actually all are in the same direction. I am telling you why the third is different from these 2. The reason is that because it is sensory and also it is having a motor component also. So if this is V and then it has the 3 divisions here, so one division which is in fact is supplying the area above this lateral angle of the lateral canthus of your eye, you will call this nerve as the ophthalmic nerve. Ophthalmic, it is V again, it is obviously fifth nerve, but you say it is the V1. You can say first division of the fifth cranial nerve, first division of the trigeminal nerve. And this is the first division of trigeminal nerve which we are going to discuss, V1, that is called the ophthalmic nerve. Below this lateral canthus level, up to the lateral angle of the mouth, this area is the area of the maxilla, so we call them the maxillary nerve. V2 should be called as maxillary, it's the official number of the maxillary nerve. V2, V means 5, 2 means 2. Second division of the fifth nerve is called the maxillary nerve. Again purely sensory. It doesn't have even a single motor fiber. Ophthalmic also, purely sensory, it doesn't have a single motor fiber also. You say the eyeballs are moving. Why the ophthalmic nerve is not having the motor fibers? Ophthalmic nerve will not have motor fiber. The reason is because these nerves basically come and belong to the pharyngeal arches. And if any pharyngeal arch muscle emerges from the pharyngeal arches, they are skeletal also, but they are less skilled. For the eyeball movements, we need highly skilled muscles. For this purpose, we need the muscles which develop from the somoids. The muscles which develop from somoids, they need actually a component, not the mesenchymal or visceral component they need here, the somatic component, because they are highly skilled. And here, if you are coming here to the motor and sensory, that is called the next one, this is called the V3, that is called the mandibular division of trigeminal nerve. This is mandibular division of trigeminal nerve. This is the nerve which is sensory as well as motor, means all the motor fibers of the trigeminal nerve, they all are distributed in the mandibular nerve, because mandible moves for the muscles of mastication and to some other muscles also. So these are, and all these muscles, because this nerve in fact reminds us of the first pharyngeal arches, so all the muscles which will be supplied by the mandibular division of the trigeminal nerve must be from the first pharyngeal arch mesenchyme. Mesenchyme. They develop from mesenchyme, but that is a somatomeric mesenchyme. That is not a general mesenchyme, that is a somatomeric mesenchyme. If it is a mesenchyme, but it will be mesenchyme, no somites. And if the somatomeric mesenchyme will give rise to certain muscles, they are skeletal, but these skeletal muscles must be called as the visceral muscles, because they develop from mesenchyme, somatomeric mesenchyme, though it is not general mesenchyme, but it is special mesenchyme. Somatomeric you can call it a special mesenchyme, because the muscles which develop from this mesenchyme, being visceral in origin, but turn out to be skeletal by nature. Skeletal by nature, developing from mesenchyme, this is not the general rule. This is the rule which is in fact has been broken here. Some concession, in fact, some kind of some special permission has been given to these mesenchymal muscles because of their capability, because they have developed from somatomeric mesenchyme. So they have been actually allowed this special permission, but they will be labeled as mesenchymal, but you call them special mesenchymal, special visceral. That is why the group of neurons supplying these muscles should be called as the special visceral efferent group of neurons. Otherwise, we always know that in the spinal cord, even in the brain stem, we have got either a general visceral efferent, autonomic, or general somatic efferent, voluntary, I say somatic. But this time it is the special visceral efferent, being visceral, but because it is special, should supply skeletal. And which is skeletal muscles? The skeletal muscles which are developing from first pharyngeal arch. That is why the trigeminal nerve is coming to supply them. Through which division? Through one of its divisions here. And that division is called the mandibular division, which we will discuss later. And maxillary also later we will discuss. So this is now the maxillary, I said this is now ophthalmic nerve, which we are actually going to discuss here. Now we have already told you that you have to discuss any cranial nerve. This is one of the divisions of the cranial nerve. This is one of the divisions of your trigeminal nerve. Any cranial nerve that you have to actually discuss here, you have to discuss here under certain headings. You see 10 to 12 headings will be there like. And these headings will be number 1, just introduce this muscle. I said introduce this nerve. This is, you know, that is the 5th cranial nerve. This nerve, especially the trigeminal, which I am actually telling you, you say this is the nerve which supplies the first pharyngeal arch muscles, but because this is mixed nerve, because any nerve which in fact is supplying the muscles of the pharyngeal arches are supposed to be mixed, always they are mixed, means they will be having a motor component as well as sensory component. And this nerve which we are going to discuss, actually this nerve rules the entire territory of your somatic area of your head and neck, of your head. Entire head area. Head area means which part of the head? The part which is related to the face area. Half of the scalp here up to the vertex, you see, have a coronal section over the vertex. You see the part of your face or the part of your head that will come in front now, all will be in the range of 3 divisions of the trigeminal nerve. Somatic means surface. Not just surface, when the fissures or foramina of anything is there, when you go inside the fissure, inside the cavity here, inside the cavities, up to 2/3 of your oral cavity, trigeminal, because this is somatic area. When you go here through your palpebral fissures here, eyeballs, 1/3 of the exposed part of the eyeball that is covered by the conjunctiva, that is actually having the cornea in it also. All it will be covered by, all it will be innervated by trigeminal nerve. Even your eyelids, inner aspects, everything here. These 2 holes here, in the nasal cavity you will go up to the top here, you see that all will be somatic zone, you say trigeminal nerve. You will go into your external acoustic meatus until the surface, outer surface of tympanic membrane will stop you up to that area, somatic, trigeminal nerve. These all areas are not just surface. Up to the vertex, I say. Behind the vertex, this whole zone is actually the posterior side, this is all spinal nerves again. More close to the center, posterior rami, more laterally anterior rami, but spinal. Which is spinal? Obviously cervical. Which cervical? Upper 4. Why not lower 4? Lower 4, you know that they form brachial plexus. Upper 4, if they are anterior rami, they will also form plexus, this is the cervical plexus. But the posterior rami, they never form plexuses, never ever. You see that even cervical, thoracic, even lumbar and sacral, they don't form plexuses. Plexuses are always formed from anterior rami. Always form from anterior rami. That doesn't mean that anterior rami are bound to form plexuses. In thoracic nerves, anterior rami, they don't form plexuses. But whenever the plexus will be formed, it will be from anterior rami. And these thoracic nerves which do not form plexuses, we call such anterior rami of the thoracic nerves as the intercostal nerves. Intercostal nerves, they do not form plexuses. They contribute, but they do not form. Now, in this area especially, when you are actually discussing here, name of this nerve, you know that it is the trigeminal, but in 3 divisions you are discussing, a separate nerve basically, each has the separate distribution, nothing to do with the other nerves. If you are discussing ophthalmic, you do not have to remember even maxillary. If you have maxillary, you do not have to remember mandibular ophthalmic. If mandibular, you can't actually, you do not have to remember and have mixed. No branch of your ophthalmic have anything to do with the branches of the maxillary, and likewise no branches of the maxillary will have anything to do with the mandibular or even the ophthalmic. They are having a separate distribution. Territory are separate, with the territory of each of these nerves is separate. So, this is why we are discussing under single heading, you see the trigeminal nerve, because when they emerge from the brain, at that time their root is common. That roots become now divided into 3 parts later on, so much so that the first order neuron, which is actually in form of a sensory root ganglion, just like equal to, you see, equivalent to the dorsal root ganglion, ganglion is same even. Ophthalmic nerves, sensory neurons, ganglion, maxillary nerves, sensory root ganglion, and mandibular nerves, sensory root ganglion. They are not a separate ganglion, they are a single very big ganglion here, you call it the trigeminal ganglion. And proximal to the trigeminal ganglion, surely the root is same also. Root of the trigeminal nerve, which will later on split into 3, ganglion of the trigeminal nerve, this will be single. That is why this nerve, despite it has 3 branches, still you count this nerve as a single nerve, trigeminal nerve. Otherwise, when the divisions will be 3, every division has its own course, and they never mix and nothing to do with them, never talk with each other, except at certain points they have some connections here, because distribution of trigeminal nerve is huge. It is basically 3 nerves, not 1 nerve, but in anatomy we call it the 5th nerve, 1 nerve. Now, as far as the 5th nerve is concerned, you see little bit of introduction what you discuss, and when you will actually complete these 3 nerves, more you can introduce, because you know more about that. Just informal knowledge about trigeminal nerve. And when this knowledge about trigeminal nerve, as for the name and as far your number is concerned, always you know it is a V, V as a 3.3 means tri means tri-headed, means it is a trigeminal nerve. Name is done also. Because you already know that it is supplying muscles of mastication, they develop from first pharyngeal arch. If it is a first pharyngeal arch being supplied by this nerve through its mandibular division obviously, so pharyngeal arch muscle supplied means this must be mixed nerve. And mixed nerve means then you will count first 2 nerves, you know that 1 and 2 purely sensory, next 2 nerves purely motor, and now will be the 5th in order. Now you say it is called the nerve, that is the trigeminal nerve. Already you know that 2 from forebrain, 2 from midbrain, and now 4 from pons. And out of this 4, this is the top one, because 5th is this. After a gap from the lower pons will be, this is from upper pons, almost at the middle pons you say, and then from lower pons will be next 3 nerves together. Bring it now here. This is the site of attachment now. But you see, before the site of attachment, the point of attachment at the brain, how and from which part of the brain it emerges, because inside you will go to the brain to see its nuclei. This is neuroanatomy. And here outside the brain, when you will actually bring it outside the brain, this is a peripheral nervous system, it will be part of peripheral nervous system when it will be. Then it is head and neck now. Intracranial course. Intracranial course and relations, because within the intracranial course it has got very, very important relations with some of very important zones or the regions within the cranial cavity. Very important clinical conditions will develop, which will lead here to the problem in the ophthalmic or in the maxillary or in the mandibular nerve. Intracranial course and important relations, clinically important. Then this nerve will, at one spot it will get rid of the cranial cavity. This is now the fissure foramen or anything is exit, source of exit. You see that the gate or through the fissure foramen, meatus, canal, where from it will get rid of the cranial cavity. Because some of its areas where it can innervate should be within the cranial cavity also. Within the cranial cavity, you don't have too many of viscera. We have brain, and brain can't be supplied by its own nerves. But there are meninges. Meninges can be supplied. Sensory supply of the meninges, especially durameter, will be supplied by the nerves here. And if it is actually being supplied here, but most of remaining everything is outside here. Outside means you have to come outside here. Escape now. You say go and exit from somewhere. So that means somewhere you have to exit. So this exit point has to be Fischer foramen, etc. You have to actually see this also. After that, extracranial course. How this extracranial course will be there, and extracranially surely it will have the branches. Extracranial course means its important extracranial points here, where it has actually gone through, what is its course and relations, and then its distribution of the branches here. And then how you will test this nerve, and what will be its major clinicals, and then its BCQs, and then its clinical presentation, etc. So then you will have be good at this here, will be able to understand the nerve, its problems, how patient comes, how you will test this. But one thing which is important here, its functional components. We have already told you, and we have given here a long class on the functional components. And in these components especially, we have told you that motor and sensory components are what? Because it is a mixed nerve. So you can say a cranial nerve is there. So we have got here motor and sensory. So you have got a sensory and you have got motor. I say motor means it's efferent and it's afferent. We have given you again idea, the sensory, if this is sensory. So in the sensory again, you have seen here a special sensory, general sensory. Motor again here, special sensory, general sensory. So you can say S, G, G, S. As far as your special sensory is concerned, special sensory are two again. One is the visceral, another is somatic. As far as somatic is concerned, you have already seen somatic, special somatic, you say. You can say here, like for example, if the special somatic is there, special somatic means special senses except taste. Special senses except taste means you can say somatic are there, but special, but they are special somatic afferent. Special somatic afferent means special senses except taste. Means nerves will be except taste means we have got olfaction, first nerve. We have got optic, second nerve, and we have got vestibulocochlear, eighth nerve. So fifth is not coming here. So fifth is not coming means a special somatic afferent senses are not carried by this nerve. At least this thing is quite clear. This thing is not there. A special somatic afferent not there. This was for 1, 2 and 8. Bring up here now. This is now called a general, we say. When you are coming here, this is special visceral afferent, you see, special visceral afferent. I am bringing it later on, but you come here, general. And out of this general, you see again, general, we can say somatic, we say visceral. This time you can call it now the general somatic afferent, this one here, general somatic afferent. I am telling you here, the trigeminal nerve basically is known for the queen of the general somatic senses. Almost all the region of your face, including the 2/3 or the 1/2 of the cavities beyond your fissures or foramina, you see cavities here. This is the rule of this nerve. It's a general somatic afferent. If anybody asks you what is the sensory component of the trigeminal nerve, you will just jump and say it is a general somatic afferent. And this is called the general somatic afferent. So this component is the general somatic afferent component. Means general senses of the pain, touch, temperature, etc. of the areas through its 3 divisions, ophthalmic, maxillary, mandibular, and whatever areas are coming here. See that if you are going here inside your oral cavity, the floor, tongue, etc., mandibular, but the palate will be maxillary. And when you are in the orbit area, it will be ophthalmic. Nose will be maxillary. Palate is maxillary, nose is maxillary. When you go here into the eyes inside, it will be ophthalmic. Tongue will be, mandible will be, even in the inside your, this all area, means here the mandible, means here the tongue also, because tongue is lying on the floor. And then here on the side here you see jaw, as well as here we are going here inside your ear, up to the tympanic membrane, it is a mandibular. But mandibular, which type of sensation? Even up to the scalp, here ophthalmic. On the sides it will be maxillary, on the back it will be mandibular, but they are general somatic afferent senses. Touch, pain, temperature, etc. You have a pain in the ear, that means here it is. You have the boil or you have inflammation here in the external acoustic meatus, mandibular. You have the pain in the eyes, you see that ophthalmic. You have the pain here in the teeth here, upper teeth here, maxillary. Well, lower teeth is the mandibular. You have problem here on the anterior two-third, on the side of your tongue here, mandibular. Problem in the palate here, maxillary. You have got problem inside the nose, boil, everything, maxillary. But in the tip of the nose, etc., again ophthalmic. And the pain is carried by these nerves here. Through the, obviously the neuron, we have told you that the senses in fact will travel when the stimulus is applied here to the receptors, transduce them into impulses. Impulses are carried by the first order neuron, and first order neuron is carried by one of the divisions of the nerve, depends which is the territory. Now if for example you are watching here, so general somatic afferent is the basic component of your trigeminal nerve as far as sensory component is concerned. When you come here to the visceral zone here, visceral, I told you that this is not the visceral nerve. This is basically, as far as sensory is concerned, it is a somatic nerve. Somatic means it should have a special somatic, it should have general somatic, special somatic not, because for special somatic we have got specific, highly pure, we say that very purely sensory nerves we have. But this is because mixed nerves, so special somatic afferent component she will not carry, because for special somatic component we have already specified 3 nerves. No nerve can come here in the special somatic afferent category except 3 nerves which are related to the special senses minus caste. So which other component is remaining? Which is somatic, not visceral I say, not special visceral, not general visceral. It will be special I say general somatic afferent, pain, touch, temperature of the 3 territories of your face as well as your oral cavity, nasal cavity, orbit and ear up to external ear. So this is the general somatic afferent. So one component only. Mixed nerves has the capability to carry maximum 3 components, but she is not carrying 3, she is carrying just 1. Which one? Somatic one. And which somatic one? General somatic, because she is the queen of general somatic afferent sensations, not the special somatic afferent. Special somatic afferent already I told you. General visceral and visceral and special visceral is test, because she is not visceral, so she will not take test. General visceral, because she is not visceral as far as sensation is concerned, she is not visceral, so general visceral even if she will not carry. Only one component is carried by that, is called general somatic afferent. That's why it's famous, very big territory. That's why it has the 3 representatives to reach in these areas, distant areas. Now come to your motor now. Motor means efferent. Already we told you that we have here, for example, you see somatic and visceral. You see it is a visceral is somatic. Somatic efferent, visceral efferent. So which efferent it will carry? Not somatic efferent. Reason? Because she is famous for those muscles. Because you know that mixed nerves we remember through what? Mixed nerves we remember that it is in fact those muscles which are, because it is supplying those muscles which are developing from the pharyngeal arches. Pharyngeal arches muscles are visceral muscles, but they are special visceral. So that means it will be visceral, but not general visceral, but special visceral. Means this is famous for a special visceral efferent component. Here it is visceral, because special visceral efferent component. Special visceral efferent component means it will have first pharyngeal arch, means muscles of mastication. So these are the 2 components. You say, sir, why not general visceral efferent? Actually, any nerve which has the special visceral efferent component must have general visceral efferent component also in the mixed nerves, except this nerve. As far as somatic is concerned, because for somatic purpose we have somatic, but for somatic again you can see we have if you have somatic we have got general somatic and special somatic. Special somatic is not present, general somatic is present, general somatic efferent. But general somatic efferent is the component that is carried by those specific those purely motor nerves which supply extraocular muscles and the tongue. Means this will not carry. For that purpose, for general somatic efferent purpose, we have actually your 4 purely motor nerves. So nobody is touching them. So what is remaining now? Remaining will be here special visceral efferent component and general visceral efferent. General visceral efferent means smooth muscle, etc. here, autonomic. So all your mixed nerves, because they are famous for carrying the fibers for the pharyngeal arch muscles, special visceral efferent muscles, and all of them which are carrying the special visceral efferent must carry general visceral efferent, means autonomic also. All mixed nerves are carrying them along with this, but only this nerve which you are discussing, trigeminal, actually refuses to carry. Probably she was also having general visceral efferent fibers here. So general visceral efferent fibers means autonomic fibers, means parasympathetic fibers, probably. Well, evolutionally, probably they have been snatched by the oculomotor nerve to carry them here to the ciliary muscle and the constrictor pupillae. So she is actually left with only one motor component. Obviously, one must be there because all mixed nerves are remembered for their special visceral efferent component. That's why it is also having this. So it is having also this. So this nerve actually is having 2 components here, you can say, as far as your sensory is concerned, because she is famous for general somatic efferent sensory modalities. That's why it is general somatic efferent. As far motor is concerned, because all the mixed nerves, they are in fact remembered for their quality to supply the muscles developing from the mesenchyme, somatomeric mesenchyme of the pharyngeal arches. And these mesenchymal muscles, you know, that are supplying here by the special visceral efferent neurons. So the component that will be the motor component is called the special visceral efferent. This must be with them. Every mixed nerve has this compulsorily. So it will have these 2 components only. Otherwise, the mixed nerve has the capability to carry out of 3, maximum 2 motor components, and out of 4 sensory, 3 should be actually carried by 3 maximum can be carried, but she is carrying only 1 from motor, only 1 from sensory. 1 from motor is the general somatic efferent, and 1 from sensory is the general somatic efferent, and 1 from motor is the special visceral efferent. Special visceral efferent means these are those fibers, these are special visceral efferent are the fibers of those neurons which in fact will come outside here, form the motor root of this nerve, distributed to only one division, mandibular, to supply the muscles of mastication which develop from first pharyngeal arch mesenchyme, somatomeric mesenchyme. And as far as the sensory is concerned, you say sensory can be pain, touch, temperature, vibration, 2-point ischemia, everything, all sensory modalities. After you have 3 different territories, through 3 different divisions, but their cell body lying in the single big sensory root ganglion, which usually in your spinal nerves is named as dorsal root ganglia, but here we do not call them dorsal because ganglia are not lying dorsal, because dorsal is not a territory supplied by the cranial nerves. Everything is ventral, everything is front. That is why we do not call them ventral root ganglion even sometimes. We just call them sensory root ganglion, so much so that even they are named behind their specific nerves. Because now all the ganglia, all the nerves have the ganglia, because motor nerves, they do not have ganglia. And sensory nerves, even they were not having ganglia because their cell bodies, you know that, purely sensory nerve, their cell bodies were scattered in form of bipolar neurons. So these are the mixed nerves, their sensory roots are having ganglia. So there are few nerves, mixed nerves are of 4 only. So the ganglia will be named behind their names, you see that. That is why the ganglion of your trigeminal, obviously sensory root ganglion, you call it the trigeminal ganglion. Very big ganglion. And the trigeminal ganglion contains the cell bodies of all 3 divisions in just one house, in one big ganglion. You call this ganglion as the trigeminal ganglion. Now, in this especially when you are actually discussing here, now see, this was the functional components. All the nerves, in fact, they are functional components. A name, introduction, name, then the number, functional components. Then you will see that, okay, where from, at what position, at what location they emerge from the brain. We have already noted that they emerge from the upper part of the pons here. So, okay, see upper part of the pons here. Watch this brain stem structure. See, this is brain stem. We will do in discussion will be actually in detail when we will be discussing the neuroanatomy, but at least you should know when you are discussing here like your spinal nerves, they emerge from the posterior side of your spinal cord, posterior horn of Grimeter, here this and this, you know about them. So, here should be also these things. Like for example, you see here, this is now your midbrain. This is pons and this is medulla. These are the three parts of the brain stem. These three together are called the brain stem. Now, as far as your brain stem is concerned, we have already told you this was your third nerve. This is your fourth. This nerve is the fifth nerve. This nerve which we are going to discuss. This is a trigeminal nerve. As far as your trigeminal nerve is concerned, you can see here in the trigeminal nerve, this is its larger lateral sensory root. While it's larger because it will actually distribute further. It's a general somatic efferent fibers in three different divisions. It will spread. That's why this is a very big root. You see that lateral smaller sensory root. Medial, lateral larger sensory root, and medial smaller will be the motor root. This green color which has been shown here is the motor root. And these motor fibers, you see that is called the motor root. This green color is motor root. And this one which I am telling you, it's called the sensory root. Of your trigeminal nerve. Still, ophthalmic nerve has not emerged from here. It is not actually has taken birth from the inside of the trigeminal yet, because it is still trigeminal. Bigger lateral sensory root, red color you see that, and a smaller motor, green color this root is there. This all the motor root fibers will be distributed to the mandibular division of trigeminal nerve, because mandibular is a nerve which will have sensory as well as motor fibers. Ophthalmic will have just sensory and maxillary will have just sensory. Which component? Obviously general somatic efferent, because it is carrying just one component. A motor component will be which one? It will be also special visceral efferent component, because it is carrying just one. And this is something which you are actually watching. This is the attachment in the brain stem of your nerve, that is called the trigeminal nerve. Okay, attachment done. Name, introduction, number, functional components, attachment done. Now it is the intracranial course. Emerging from your brain stem, it now travels now. It travels within your cranial cavity, and within your cranial cavity is very, very important again. You see the within your cranial cavity, it is important intracranial course. Okay. See its sensory root is very important here. See its sensory root. After you see that sensory root is emerging, the sensory root should have immediately, like the posterior root of your spinal nerve, it emerges and it proceeds here towards the intervertebral foramen, where you know that it mixes here with, it fuses with the motor root also, but you know that within the intervertebral foramen it has the ganglion, dorsal root ganglion. So it should have also a ganglion, not any foramen though. Within the cranial cavity it will have a ganglion. It will have a very big ganglion. And that ganglion, you can say, this ganglion is present, if you remember here, this is your cranial cavity. This is a lesser wing of sphenoid. You are watching here. This fossa is called the anterior cranial fossa. This one is called the middle cranial fossa, and this is called the posterior cranial fossa. already has, you see that you have a good idea that the anterior cranial fossa, middle cranial fossa are separated here by the lesser wing of the sphenoid. It's like here. Middle cranial fossa and posterior cranial fossa, they are separated here, you see, demarcated by the superior part of petrous part of temporal bone. This is this petrous part of temporal bone. This broken line which I am actually drawing here, this is the superior border of the petrous part of temporal bone. So here is the posterior cranial fossa, middle cranial fossa here. Now this petrous part of temporal bone, which in fact emerges like a big wider base, you see that from the squamous part of temporal bone, now travels here, it is lying on the floor of your cranial cavity, and it has got now this apex, it is called the medial tip, you can say. Laterally it is a broader base and it has got the medial tip here. It has the anterior surface towards the middle cranial fossa and posterior surface towards the posterior cranial fossa. And in the middle cranial fossa you have already seen the foramina. Foramen rotundum, foramen ovale and foramen spinosum. You see here it is called the rotundum. This is called the foramen ovale and this is called the foramen spinosum. These three foramen are there, and then you have seen again here in this area carotid canal also. But whatever is there, this is the anterior surface of your petrous part of temporal bone. This is the posterior surface where you see this internal acoustic meatus. But watch here, this petrous part of the temporal bone, which I am actually showing you here, its anterior surface towards the middle cranial fossa, its medial tip here. So anterior surface of the medial tip of your petrous part of temporal bone. This is the location where you can actually see here a depression of the bone. Bone is depressed there. Even little finger, you can, pulp of the little finger you can actually put into that depression here. That depression is called Meckel's cave, and its name is the trigeminal cave also. And this is the cave which accommodates a very big ganglion that is called the trigeminal ganglion. So here is lying actually the trigeminal ganglion. Which you know that it was a root before here. So that means root, terminally the root, this big root which we saw here, it terminates into a bulging, that is the ganglion. So here is the ganglion, where at the anterior surface, anterior depressed part of the medial tip of the petrous part of temporal bone, very close to the body of the sphenoid. There already you know that cella turcica etc. is there, but this is now you see that is called the trigeminal ganglion. You call this ganglion as the trigeminal ganglion, and this is called the area, and the area, depressed area, is called the trigeminal cave, or you can call it the Meckel's cave. It is a depressed bony area, but this bony area is wrapped up by the duramater above. So that means a room will be created which is all around bony, but this roof will be formed by the duramater. So you are protected now from the pressure of brain or etc. You see that. So Meckel's cave is actually something in which it is wrapped up here, roofed by the duramater. So that means the ganglion which is actually lying there, it is extradural, outside the dura. So this is an extradural space, you say. So Meckel's cave is an extradural space which is from all sides bony, but its roof is covered by the duramater here. So this is what we call here the trigeminal ganglion, important, very important trigeminal ganglion. This trigeminal ganglion contains first order neuron cell bodies, and these first order neuron cell bodies in all sensory cell bodies, except if they are they belong to this purely sensory nerves, they are all pseudo-unipolar. Even your test fibers, you see that, have got the first order neuron pseudo-unipolar. All general sensory neurons related to your first order neuron, related to your sensory signals, they are first order neurons. So they are also first order neurons, and their cell bodies are lying here. And these cell bodies belong to which division of your trigeminal division? All three divisions. all three divisions actually lying under same roof. Cell bodies of all, they are lying in the same here. Until here it is all trigeminal, but from the anterior edge of your trigeminal ganglion will emerge now three divisions. Three divisions means if I am telling you this is a ganglion, and this ganglion is a trigeminal ganglion, and this is the cell body which is actually, I am giving you just one cell body. This is pseudo-unipolar, so it should have the one axon, which now should have a peripheral axon splitting and now central axon. Central axon will constitute the sensory root of your, this is one cell body I am showing you. I am showing you another cell body, for example. This cell body incidentally belongs to, for example, there are thousands of them. I have heard somewhere that it is having actually 1 million neurons. So, if for example it is having here maxillary, say ophthalmic cell bodies, so it is central axon, it is peripheral axon, and peripheral axon will run with the ophthalmic nerve. It will constitute the ophthalmic. This is the beginning of ophthalmic nerve, but here proximally it will be, this will be the sensory root of not ophthalmic but maxillary, because the root is common. Next neuron, because this belongs to the maxillary, so it will also have, for example, you see pseudo-unipolar, so central axon, peripheral axon. Peripheral axon will run with the maxillary nerve, and the central axon will run with the same sensory root of your trigeminal nerve. Then you have got, for example, another group of neurons related to the mandibular, sensory part of the mandibular, will have pseudo-unipolar, will have now a central axon running along with the sensory root of this time, not mandibular, trigeminal, because root is common, and then here is running the mandibular nerve. Means from the anterior edge of your trigeminal nerve will emerge your three branches now, but the proximal portion will have not three branches but just a single root here. That's why this nerve is actually counted as a single nerve. Otherwise you see from the anterior edge there are three nerves here, but at the attachment time they are single. That's why this nerve is counted as a single nerve, but it has three divisions, because this nerve is V, means fifth nerve, but it has now V1, it has the V2 and it has the V3. So now you can say my ophthalmic nerve, it emerges or it starts at the anterior edge of the trigeminal ganglion. This is the beginning of your nerve basically, but because you are not discussing just the ophthalmic nerve, you are actually discussing the trigeminal. You will discuss the ophthalmic separate, maxillary separate, mandibular separate. That does not mean you will study mandibular separate, I say trigeminal separate. Trigeminal will be, actually the word trigeminal will be up to trigeminal ganglia. Beyond that, now it is the story of the three nerves separate. Now in this, especially when this is now here, so you are starting from where? You are starting here from the anterior edge of, this is the anterior edge of the trigeminal ganglion. Your ophthalmic nerve starts with just one type of fibers only, purely sensory. But it is not a purely sensory nerve. Nerve is trigeminal, but you know that is containing motor fibers also. Otherwise, ophthalmic nerve would have been actually another purely sensory nerve. But an ophthalmic nerve itself is not a nerve, it is only the division. And this division is actually carrying only the sensory fibers. And those sensory fibers have actually first order neuron obviously, and they have the cell body present in trigeminal ganglion. Ganglion is trigeminal, it is not ophthalmic ganglion. If the ganglion would have been ophthalmic separately, a root of the ophthalmic would have been separate, then the ophthalmic nerve would have been a separate nerve. Why trigeminal? Trigeminal would not have been a nerve. Then maxillary would have been separate also, mandibular separate. If all these three nerves have a separate root, separate ganglion, then why you are counting them as a single nerve? Single nerve, because their root is common, even ganglion is common. Beyond that, now their directions or their destinations separate here. And here if you are actually watching in this, so it is V1 and V2 and V3, so you are looking at V1. V1 means now you are actually looking at the V1, and if the V1 means it starts here from the anterior edge of your trigeminal ganglion. This anterior edge of the trigeminal ganglion, watch it, is a very important thing here. Now here in this region you are watching, this is the cranial cavity. You are seeing in the middle cranial fossa. In the middle cranial fossa, you know that this is called the sella turcica. Why we have actually advised you to do the osteology first, because everything which is running here within the bones now, and within the bones cranial cavity, if you haven't done the cranial cavity, then how you will be able to understand what are these things and where you are, where the trigeminal nerves, ophthalmic division, everything is going. That's why the osteology must be in the head and neck. Do the osteology first. no matter how many days it is actually taking. Not just osteology, you have to do here the fissures, foramina, this and that, even the cavities like the orbit, infratemporal fossa, temporal and pterygopalatine. Then preferably even the nasal cavity if you have done, oral cavity if you have done. Do them, no bone is left, then the soft tissue now. And the last should be the nerves and arteries, etc. And here if you are picking up here, I told you that now ophthalmic nerve starts. Ophthalmic nerve starts from the anterior edge of your trigeminal ganglion. Two more nerves are also there, but you watch just trigeminal nerve. I say ophthalmic nerve. Ophthalmic nerve V1. It's going here. Now it is going here. You can see it is going very close here to the central part of your sphenoid bone, body of sphenoid, where there is a sella turcica. It is running on the side of it now, and on the side here there is a groove. Just like Michel's cave or the trigeminal cave or a depression here like this, depression where the trigeminal ganglion was settled and overlying will be my dura mater. Similarly here on the two sides of your sella turcica, there is a longitudinal groove this time. It is not a depression as such, it is a longitudinal groove, means it will be just like a full length of the side of your, on both sides here. And when it is on the both sides will be here, you will see that this is not just the groove on two sides. You see I am making in dotted here, this is the groove on two sides of your sella turcica, which is lying in the body of the sphenoid on the two sides here. This is the groove, bony groove. That is the bony groove on two sides here. And in the bony groove, so in your sella turcica is located pituitary gland. And the central part of the sella turcica, which is name is hypophyseal fossa, pituitary fossa. So it is the pituitary fossa in which is here, but on the sides you see that you are sitting, you see you are sitting here in the middle, on the sides here, left and right here, both sides. You have got a groove. There will be like these grooves. These grooves are there, okay, it is true. But when these grooves will be covered by the dura mater, why you want to cover the dura mater? Because the sella turcica where your pituitary gland was lying, you want to give the floor, I say a roof to the top of the pituitary gland to protect it from the weight of the brain, because it is suspended from the base of the brain. That is a very small object, you see the very small organ here, a small gland, master gland you call it, but very small in size. So maybe it is suppressed here, so maybe it is compressed by the weight of the brain here. So nature has provided here a bony casing here, but bony casing has no roof, but the roof is covered by dura mater. When the roof of the sella turcica is covered by the dura mater, surely these two grooves are which are lying parallel on one side and the other side here, they will also be covered. Means groove will be bony, but this roof will be formed. It is not just roof, but the lateral wall will also be formed by the dura mater. Means it is a floor and medial wall, bony, but its roof and the lateral wall will be dural or a dura mater, meningeal. So when the groove on the both sides of the sella turcica that has been roofed by the dura mater, a sinus has been created, you call it now cavernous sinus. This cavernous sinus, if you are actually looking at this, if you look at the cavernous sinus superiorly, it is almost, you can say, it is almost spindle like, you see it. It has got the anterior narrow end, has got the posterior narrow end, and it has got the middle wide belly, you can say. It is kind of spindle like, fusiform, you can say, in such a way that it will look like this. You see here, there is like a fusiform here. Posterior end, or you can say posterior tip, it will be just like you can say like this. It has got the anterior pointed end and has got the posterior pointed end, and the middle belly will be thicker. But this anterior pointed end will finish, you see that ends at the most medial end of the superior orbital fissure, and the posterior pointed end, it will finish, or you can say it will start at the medial tip of the petrous part of the temporal bone. It stretches between here. So one here, and similarly symmetrical another cavernous sinus on the other side here. Both these cavernous sinuses, they are in fact connected by means of intercavernous sinuses also. Anterior intercavernous sinus, posterior intercavernous sinus. Anterior intercavernous sinus that in fact travels across the body of the sphenoid bone anteriorly along the sulcus chiasmatus, and the posteriorly will be along the dorsum sali, you can say. Both the cavernous sinuses are connected, so that the pressure if on the one side is more, it should be in fact shifted to the other side via these intercavernous sinuses. These are basically venous sinuses. They collect the blood mostly from the eyeball, and at times you see that it will collecting the blood from the superficial veins of the cortical veins of the surface of the inferior surface of the brain also. And after that it will put its blood here into finally directly or indirectly into the internal jugular vein. But you watch it here, we told you that this is a cavernous sinus, and this cavernous sinus on two sides you see it has been actually floor as well as its medial wall formed by the body of sphenoid bone, that is forming the sella turcica also. It has been roofed hereby. It is not just roofed, but the lateral wall as well as the roof is being formed here by the dura mater. And that dura mater is not just covering the sella turcica, and it is not just forming a sella turcica, and that sella turcica has been roofed by this fold of the fold of the dura mater. But similarly, it will be actually forming the roof as well as the lateral wall of the cavernous sinuses on both sides also. So much so that the sella turcica has been actually partitioned by the rest of the cranial cavity. That is why you can call this fold of the dura mater as the diaphragm. You call it the diaphragm of the sella, and its name is the diaphragma sali. Diaphragma sali is actually the fold of the dura mater that separates the hypophyseal fossa from the rest of the cranial cavity. Means the rest of the cranial cavity is accommodating the brain, and the sella turcica is accommodating a small piece of this is a small gland here, that is the pituitary gland. So pituitary gland has been in fact freed from the pressure from the size of the brain here. So it will not be pressurizing it, because the sella diaphragm sali has actually separated it. But in the diaphragm sali, in the diaphragm of the sella, there is a small hole through which the stalk of the pituitary gland is in fact coming. I will show you this also, but you see this is a sella turcica and a cavernous sinus, and here the cavernous sinus is important in such a way that if you see this cavernous sinus as a whole, this is a paired sinus connected by means of the paired as a other sinuses, interconnecting sinuses, you call them intercavernous sinuses, anteriorly and posteriorly also. But you see that posteriorly it is coming from the tip of, starting from the medial tip of the petrous part of temporal bone, and anteriorly it stops at the medial end of the supraorbital fissure here. Now we are actually discussing here, we want to see here the lateral wall of the cavernous sinus, which has been in fact formed here by the dura, and surely by the superior wall also. Roof is formed by the sella also. You look at this now. Now in this area you are looking at this. I am darkening here. You see this dura mater forming the lateral wall. This dura mater is forming the lateral wall of the cavernous sinus. And this is not just forming the lateral wall of the cavernous sinus, but at the same time it is forming here the roof also. See, this roof is being formed by this also. So the roof is being formed by this as well. And not just this roof, and so roof is being formed by this also. And you can see here there is a hole now, because it's reflecting in such a way that it can return back again here. So there is this is now your pituitary gland stalk here, and this is the pituitary gland itself going here. So this is the opening through which the stalk has gone. So that means the stalk is now accommodated by this hole now. And here I am actually showing you here this cavernous sinus. Cavernous, it is spongy, you see that it is compartmental. So it is compartments are there, so that when the blood actually accumulates in the cavernous sinus, it should be distributed in various compartments, so that the walls of the cavernous sinus, especially the dural walls, they do not feel the pressure here, because the pressure has been distributed in various columns. Especially in the lateral wall of the cavernous sinus, we should not actually feel the pressure. Reason is that because the lateral wall of the cavernous sinus gives here passage to almost all those nerves which in fact want to travel through and will try to reach the orbit here, and reaching the orbit is the most probable best pathway is the supraorbital fissure. So if any nerve which emerges from the brain tries to go into the into the orbit here to supply the muscles, especially the muscles and even the sensory supply also, so want to go there, the passage is or the exit is through the supraorbital fissure, and all these structures they will try to run through the wall of the cavernous sinus, lateral wall of the cavernous sinus, not the roof, because the floor and medial wall they are the bone already. This is the body of sphenoid bone on the side of the sella turcica in the body of sphenoid bone, but here this is the lateral wall. So lateral wall actually is giving passage to one by one the nerves, like the one brick, then another brick, yet another brick, yet another brick. You see, in layer wise they are. In layer wise, the lateral wall of cavernous sinus is very, very important here. That's why the lateral wall of the cavernous sinus, which is formed of the dura mater here, has to be saved from the increasing pressure within the cavernous sinus, which is receiving the venous blood from various parts of the brain here, including eyeball also. So you have to actually look at the lateral wall of cavernous sinus here. The lateral wall of the cavernous sinus, the highest nerve in the lateral wall of cavernous sinus is this green color, which I am actually showing you here. This is your third cranial nerve. This is oculomotor nerve. This is nerve number 3. When you come here, the next after that is the nerve number 4. This is trochlear nerve. Why? Because both of these nerves, their target is, their destination is the orbit to supply the extraocular muscles. That's why they want to, in fact, to go through the supraorbital fissure. So going through to supraorbital fissure, from brain to supraorbital fissure, middle cranial fossa has to be travelled, and travelling is in the cavernous sinus on two sides of the sella turcica. Going into the cavernous sinus, which wall? Lateral wall. Lateral wall nerves, these usually are asked in the examinations. Name the nerves running the lateral wall of the cavernous sinus in order from above downward here. Above downward means superiorly to inferiorly. The top nerve is the third nerve, next is the fourth, next is the fifth. You see, the fifth means the trigeminal. Trigeminal, because this nerve should be, because it is going to the supraorbital fissure, so it will be V1 nerve. That is called the ophthalmic nerve. So it will be, next nerve is this nerve also, V1. That is called the ophthalmic nerve. Ophthalmic division of the trigeminal nerve. Actually, there is fourth nerve also, means this is next nerve also. The 3, 4, V1, V2 also. So V2 also enters here. Enters in the lateral wall of the cavernous sinus after ophthalmic. This is called the maxillary nerve. Maxillary branch of the trigeminal also runs in the lateral wall of the cavernous sinus. But this will run into the entire, say, through entire length of the lateral wall of cavernous sinus. But this will actually fall short of the superior orbital fissure, because it doesn't have to go to the superior orbital fissure. And because it doesn't want to go into the superior orbital fissure, little less, you see, the little short of the superior orbital fissure in the floor of the middle cranial fossa, posterior lateral to the medial end of the superior orbital fissure. You can see here, this was actually superior orbital fissure. This is little lateral and say lateral posterior and lateral. Posterior lateral to the superior orbital fissure, there was lying here a foramen, rounded foramen, rotatory foramen. You call it the foramen rotundum. This is foramen rotundum. This nerve V2 in fact will not go into the superior orbital fissure. This will enter into the foramen rotundum. That we will actually discuss later. What about the V3? V3 has nothing to do with the orbit, nothing to do with the foramen rotundum. It will actually fall even shorter, well short of even the lateral wall of the cavernous sinus. It doesn't enter into the cavernous sinus at all, because very close to the medial tip of the petrous part of temporal bone, just inferior to the petrous part of temporal bone's medial tip is lying the foramen ovale. Why this nerve will actually enter into the lateral wall of cavernous sinus? It doesn't enter into the lateral wall of cavernous sinus. So V2, in fact, the V2 means the maxillary nerve, or the last nerve in the lateral wall of cavernous sinus after third, fourth, fifth. Fifth meaning V1, V2. Ophthalmic and maxillary. 4 nerves run from superior to inferior in order in the lateral wall of the cavernous sinus. And out of this, the 3 nerves enter into the superior orbital fissure. The 4th nerve will actually be, this is called the V2, that is the maxillary nerve that will enter into the foramen rotundum, well short of posterior lateral to the medial end of superior orbital fissure. Okay, what about the 6th cranial nerve? 6th cranial nerve also emerges from the brain. It will also travel, has to enter into the orbit, again into the superior orbital fissure. But this will not enter into the lateral wall of cavernous sinus, because it is so medial that it will pass through the cavernous sinus. You can see this. See this green color nerve which has been actually shown you here. Inside here in the network, that is, network means it is compartmental, spongy, cavernous word you have seen here, the corpora cavernosa, cavernous, spongiosus, cavernosus, this is cavernosus, this is called the sinus cavernosus, that is called the cavernous sinus, and this is having a venous blood here. So here you see this big red which I am actually showing you here, this is the internal carotid artery. And inferolateral to the internal carotid artery, there is this nerve that is called the sixth cranial nerve. So this is the sixth cranial nerve that is actually, and this is called the abducens nerve. This is your sixth cranial nerve. Now you can imagine that cavernous sinus, either lateral wall or through it, 5 nerves are actually related to that. 5 nerves you have seen here, 2 divisions belong to the same nerve. You can say 5 nerves are related. Third nerve, lateral wall. Then the fourth nerve, lateral wall. V1, that is the ophthalmic, lateral wall. Then is the V2, maxillary, lateral wall. Through in the cavity of the lateral wall of the cavity of the cavernous sinus, inferolateral to the internal carotid artery is the abducens nerve. Abducens nerve passes through and straight away it will go into the superior orbital fissure. This is another nerve that will enter into the superior orbital fissure. Ophthalmic also enters into superior orbital fissure for the sensory purpose, for the general sensory purpose. This can carry even autonomic fibers also. Third nerve, it will enter also into the superior orbital fissure, but because it has to supply the extraocular muscles and the LPS is called levator palpebris superior skeletal portion. At the same time, this is called the fourth cranial nerve, again superior oblique extraocular muscles. And though oculomotor contains even parasympathetic fibers also. But ophthalmic contains sympathetic fibers also. From where it will carry the sympathetic fibers? Preganglionic or postganglionic? As far as your oculomotor nerve is concerned, preganglionic or postganglionic you have to see. If there is preganglionic, you have to look for the ganglion. If it is a postganglionic, then you don't have to have any ganglion required there. Straight away you have to actually look for the effector organ, means muscle, means smooth muscle, cardiac muscle and exocrine gland. Obviously not cardiac muscle here, but at least smooth muscle and exocrine glands. Then you will actually be watching here. So this is now your ophthalmic nerve, means if you are looking at the ophthalmic nerve, you have to look at, you see this diagram, this picture which I am actually showing you here, this is the coronal section that has been cut in the middle of the sella turcica. At the middle of the sella turcica, you are actually watching the sella turcica. This means the pituitary fossa you are actually watching, and you see this pituitary fossa, and the pituitary fossa means this pituitary fossa has been formed by the body of sphenoid, and under the body of sphenoid you know that there are sinuses, these are called air sinuses, these are sphenoidal sinuses, this is sphenoidal sinus. Both sides, so if one on one side, this you can because they are paired, and under the sphenoidal sinus you see this is a nasal cavity. Nasal cavity on this side and nasal cavity on the other side also. This is sphenoid sinus. Both sided. Sphenoid sinuses, they are both. There is a partition here. So one and one. And above that, here in the body is lying body of sphenoid. So whole is the body of sphenoid. That means the roof of your nasal cavity is being formed here, most posteriorly by the body of sphenoid. And this is the area you see that through which the laser surgeries are actually being made here. Laser intervention is being made across the sphenoid bone, through the nose, through the roof of the nose that is being made here by the sphenoid bone here. Through that, the laser access is actually to the body of sphenoid, and through the body of sphenoid to the sella turcica where pituitary gland is sitting here. So transsphenoidal approach can actually have an access to the pituitary gland for treating the adenoma or tumors of the pituitary gland. So ENT surgeons, they can do this actually, this transsphenoidal access to the pituitary gland, because the same sphenoid bone is forming the roof of the nasal cavity, and the same sphenoid bone is actually forming here the floor of sella turcica also. It's having actually a pituitary fossa, and this pituitary fossa is lying here. On two sides you see this is the cavernous sinus filled with the blood here. Spongy, you see that is compartmental sinus, whose lateral wall as well as the roof is being formed here by the fold of dura mater, that is called the diaphragma celli. And here you are actually watching in the lateral wall of cavernous sinus, this nerve, another nerve, yet another, 4 nerves, 3, this one, 4, V1 and V2, and 6th nerve you know that already is lying within it along with internal carotid artery, which has just entered into the carotid canal and makes a turn here, passes through the cavernous sinus, and when the cavernous sinus is about to finish, then again it will actually be superiorly turning here. So make here a S-like siphon, S-like curve here. Then it will actually be penetrating the durameter to strike the arachnoid, goes into the subarachnoid space at the base of the brain and splits up into the two terminal branches, anterior and middle cerebral arteries. And during this course, you know that because it is passing very close to here, the optic canal. So your internal carotid artery, before reaching the base of the brain, will give here a very important branch through the optic canal, that is called the ophthalmic artery. So ophthalmic artery will actually pass here through what? The ophthalmic artery passes through the optic canal. So see, this is optic canal, which is actually going through this and goes into the orbit here. This is your ophthalmic artery. So this was the intracranial course of your ophthalmic nerve. You know that it's attachment here to the brain. You have seen already attachment to the brain. Where it was attaching here to the brain is not attached to the brain directly, because you know that from the anterior end of your trigeminal ganglion emerges the ophthalmic nerve. Then it was intracranial course, further intracranial course here in the lateral wall of cavernous sinus. You have seen here. And for this purpose, cavernous sinus anatomy is must. And when it is reaching here, where from the cranial cavity it will make an exit? It will make an exit in the superior orbital fissure. So that means in the superior orbital fissure, you have to actually look at this. It wants to, in fact, get out of the superior orbital fissure. It gets out of the from the cranial cavity to enter into the orbit through the superior orbital fissure. Now, in the superior orbital fissure, actually ophthalmic nerve itself doesn't enter into the superior orbital fissure. Just before superior orbital fissure, it splits up into three terminal branches. And these three terminal branches, they enter into the superior orbital fissure separately. So it is not the one hole through the superior orbital fissure. In the superior orbital fissure, there are three branches of the ophthalmic artery. They will enter separately. One will be most lateral, one is in the middle, and one is most medial. These three branches, you have to actually look at this. Now, if you are looking at this three branches now, so you can say, we are actually telling you here now, look at this diagram. In this diagram, you are watching here. So see, this is the trigeminal ganglion. You will see this is your petrous part of temporal bone. This is the medial tip. The anterior surface of the medial tip has the depression that is called the Meckel's cap, that has been actually covered with the durameter extradurally. This ganglion is there. We call them trigeminal ganglion. Trigeminal ganglion. Trigeminal ganglion has pseudounipolar neurons of all the three divisions of the trigeminal nerve. And you know that this is a trigeminal ganglion, which is giving here from the anterior edge, three nerves are emerging. The one nerve that is actually the top one above, this is actually called the ophthalmic. So this is ophthalmic, V1. Next, this is a V2, maxillary. That will enter into the foramen rotundum. And the third one, this is called the V3. This will enter into the foramen ovale. But you look at this nerve that is called the ophthalmic nerve. We told you that it is running in the lateral wall of cavernous sinus, reaching the superior orbital fissure. It wants to enter and will get away from, you see, that to get out of the cranial cavity to enter into superior orbital fissure. But just before superior orbital fissure, entering into superior orbital fissure, it splits up into the three branches. The three branches in such a way that the most lateral branch entering into the lateral part of your superior orbital fissure is this. You see, this dot has been shown here. This artery, this nerve that is actually entering here. This nerve is called the lacrimal nerve. Number one. Number two, which is the middle branch, the lacrimal one, which is the thinnest branch of, you see, that of your ophthalmic. Then second branch, which is entering also in the middle part of your superior orbital fissure to enter into the orbit, and will actually be going here into the roof of the orbit here. And your lacrimal nerve more closer to the lateral wall, and here more closer here to the roof here. This artery, this nerve, the second nerve, which is actually of the ophthalmic, entering into the orbit in the superior orbital fissure directly. This is called a this is called a frontal nerve. So one was a lacrimal, second is frontal. The third branch which will be entering into the most medial part of your superior orbital fissure, because it is so medial. At the medial part of the superior orbital fissure, that will be actually entering into the superior orbital fissure directly. So these are the structures passing through superior orbital fissure, which we have probably done in the structure of the orbit, the anatomy of the bony orbit. And this is also, you see that is here, the third nerve. This third nerve is very important again. And this third nerve, which is actually entering here in the superior orbital fissure separately. You see this, I have actually giving 3 dots here. The one dot is about the lacrimal, the second about the frontal, and the third which is actually here. The third nerve which will be running here and touching the medial surface of, or say medial wall of your orbit here. This nerve is called nasociliary nerve. This is the third nerve. 3 of the terminal branches of the ophthalmic division of trigeminal nerve entering the orbit, superior orbital fissure separately into various levels here, the various parts. Most lateral, in the middle, and the most medial, entering into the orbit. Now, they are the contents of the orbit. So, ophthalmic nerve, if anybody asks you, leaves which exit point here, you can say superior orbital fissure, but now you say that it is not superior orbital fissure, the ophthalmic nerve individually is actually passing through. Just a little before that, ahead of the superior orbital fissure, splits up to the 3, and these 3 enters individually here. It is not collectively the ophthalmic nerve enters and then it splits into 3. No, before entering it splits into 3 and goes inside now, because all they are sensory. All they are sensory, but here especially nasociliary. Look at the nasociliary. Nasociliary on its shoulders actually is picking here the sympathetic fibers also. You say the sympathetic fibers, how? From where? If you remember, we told you that sympathetic outflow is a thoracolumbar outflow. You see from T1 to L2, these are the cell bodies of the thoracolumbar, means sympathetic, preganglionic sympathetic fibers. Yeah. Preganglionic sympathetic neurons collections right from T1, lateral horn of the T1 up to L2 uninterruptedly. There is a column, this is called the sympathetic column. You call it the general visceral efferent column, you know that is autonomic, but it is sympathetic. And when their axons now will be leaving, they will be leaving on the motor roots of these corresponding nerves, T1, T2, T3, likewise L2, 14 anterior roots of these 14 nerves, these preganglionic fibers will be running, and they will be coming out of the intervertebral foramina, they are corresponding, now be running on the mixed nerves and be relaying into the ganglia, which will be actually waiting outside in form of a chain that is called the sympathetic chain. And from the sympathetic chain, neurons will start now your postganglionic fibers. Because in the sympathetic chain, ganglion will be lying here, the postganglionic fibers here. But you know that these will actually be going to your surface, or can go here into your abdomen or the other regions. But who will go here to this nasociliary? Actually, the fibers which started from T1. I am giving you just example. The fibers which started here from the T1 cells here. The T1 cells means the cells present in the lateral horn of the T1. You see that lateral horn of if this is now a spinal cord here, the lateral horn of the T1 segment of a spinal cord. Lateral horn of T1 segment of a spinal cord, from here will start your preganglionic fibers. And these preganglionic fibers will come outside here. You have got a T1 ganglion, but above the T1 ganglion, we have got a inferior cervical ganglion. Above that is the middle, and above that is a very huge superior cervical ganglion. T1 fibers, most of them entering into the T1 but not relaying into T1, they will actually rise here and they relay into the superior cervical ganglion. This is I am giving you example. It is not exactly like this, but it will be almost like this. Means the preganglionic neurons are lying in the lateral horn of the T1. They are giving now the preganglionic fibers entering into the T1 ganglion, corresponding ganglion, and these fibers which I am telling you will not relay into the T1 but will rise up here, will pass through the inferior cervical ganglion, then pass through the middle cervical ganglion, and then now reach the superior cervical ganglion, where the ganglion means cell bodies are waiting for them. These preganglionic fibers will relay into them, and when it will relay into them, from the superior cervical ganglion will emerge now the postganglionic fibers. And I have probably told you before also, the last of the ganglion among the sympathetics, last ganglion is the superior cervical. Means above that level, whatever fiber you will see in the head or neck or anywhere, they must be postganglionic, because above that we don't have any sympathetic ganglion into which you can relay and you will actually bring out here postganglionic fibers. You don't have any. So that means in face, in brain, in eyes, everywhere, whatever fiber you see in form of a sympathetic, not parasympathetic, but parasympathetic ganglion are there, but it is in form of a sympathetic, they always be postganglionic fibers. So from here the postganglionic fibers are emerging, whose cell bodies are lying in the superior cervical ganglion. If they are now rising up here, you are looking for the nerves, because you see that autonomic fibers usually they don't use their own nerves, they usually accompany already existing nerves, not necessarily nerves. Sometimes when the nerves are not available, they make a plexus around the surface of the arteries even. And here these postganglionic fibers which are emerging here out of your, they are emerging out of your superior cervical ganglia, they are actually making a plexus around a very large artery, that is called the common carotid artery, carotid plexus of nerves, composed of postganglionic fibers whose cell bodies are lying in the superior cervical ganglia, and they are actually running along the, so making here a network of the common carotid artery. But when the common carotid artery splits here at the middle of the neck here into the internal and external carotid, so this network will be half will go to the internal carotid, half around the external carotid. And that internal carotid passes through the entire remaining part of the neck, enters into your carotid canal, plexus continues. And when your internal carotid artery enters here into the carotid canal and turns here to enter into the cavernous sinus, plexus continues. Which plexus? Plexus made up of postganglionic sympathetic fibers. And these postganglionic sympathetic fibers are the cell body present in the superior cervical ganglion, and they are being controlled by the preganglionic fibers present in lateral horn of the T1. And now the plexus which is around the internal carotid artery, which was actually passing through the cavernous sinus. So this common carotid artery, when it is passing through along with its plexus around its surface here, postganglionic sympathetic fibers, when this common carotid artery is actually looking laterally here on the lateral wall of the cavernous sinus, 4 nerves are running also there. You don't have to actually disturb these 4 nerves, but you are thinking that these 4 nerves are there. One of the nerves will actually take your postganglionic sympathetic fibers, 2 to 3% of these fibers, that nerve will pick up. That nerve will pick up means which nerve? Not the third, not the fourth, but V1, that is the ophthalmic. Means in order which one? This ophthalmic. You see that is the red colored artery, around that will be the plexus, and some of the fibers of this postganglionic sympathetic fibers whose cell body is lying in the superior cervical ganglia, this plexus in fact will have a little bit contribution here to what? It will mix with the already existing sensory fibers. So this sympathetic fibers plexus, some portion in fact will be joining the already existing sensory fibers of your ophthalmic nerve. So ophthalmic nerve, which was containing general somatic afferent fibers, previously pure, now it has been aided, has been polluted by the sympathetic parasympathetic, sympathetic postganglionic fibers, also whose cell bodies you know that has been lying here in your superior cervical ganglion, and they have travelled a long way through the common carotid, then through the internal carotid, and now internal carotid is this piece which is actually lying through the cavernous sinus. In the lateral wall is lying here your ophthalmic nerve, and ophthalmic nerve picks some of the fibers of here. Otherwise, all the fibers will go here along with its branches of your internal carotid artery to the base of the brain and will be distributing to the brain arteries here. But these fibers will be picked up by the ophthalmic. And when the ophthalmic here being picking up this, you see that ophthalmic when reaching here to, you see here again, the ophthalmic is reaching now here to the supraorbital fissure and is splitting up into the 3 branches, the lacrimal, the frontal, and the nasociliary. All of these fibers which it has snatched from the internal carotid artery when it was passing in the lateral wall of cavernous sinus here, all these postganglionic sympathetic fibers will be handed over to one of the 3 branches here, and that one of the 3 branches is the nasociliary, not the lacrimal, not the frontal, but the nasociliary. So it will actually be handed over to the nasociliary. So see, this is dotted, I have already told you, this is now the internal carotid artery, plexus around that, fibers handed over, you see dotted fibers red color, handed over to the V2, that is called the ophthalmic. Ophthalmic splits into 3 branches. This is called the lacrimal, frontal and nasociliary. So nasociliary will get its own share of the of your sensory fibers, but all the fibers of the sympathetic to the nasociliary. And when the nasociliary will reach here, you see that in the orbit now. So all these sympathetic fibers which it had actually carried, which it had got the inherit here from the its mother nerve, that is the ophthalmic nerve, all these fibers they will now enter here. Some of them will enter here in a ganglion that is called a ciliary ganglion, but not for relaying purpose, because ciliary ganglion is a parasympathetic ganglion, just for passing through them, so that in the posterior part of the sclera they can enter to supply the vessels to cause the vasoconstrictor effect of the vessels which are present in the choroid. But remaining fibers without passing through the ciliary ganglion, because you don't have to go to any ganglion, you are sympathetic, you are already postganglionic, you just find out your effector organ, that is the smooth muscle or the gland or your cardiac muscle. You don't have to go to any ganglion here, ciliary ganglion just to give you passage here, you are passing through without relaying at all. But remaining fibers in fact will relay, I say not relay, remaining fibers will enter into the anterior part of your sclera, so that it will actually be following and will going and entering into the iris. Iris, which muscles? The radial muscles of the iris. If you are actually looking at like iris here, iris has got the central muscles which is called the constrictor pupillae, and in the radial muscles you will actually entering here. These muscles, when they will be stimulated, they will contract. When they will contract, you see that they will contract here, the gap between these muscles, that is called the pupil, that will be actually enhanced, that is called the mydriasis. Means it will be enlarged. So pupil's diameter will be enlarged, means more light will enter. This is actually happening in the emergency. This is emergency system, that is called the system of emergency, sympathetic system. This is pupillary dilatation, you call it. In the dark light, you see that in the dim light, the pupil will actually increase in size here. This happens because of this. Means your sympathetic fibers, you can imagine that, starting from superior cervical ganglion, fibers will making a plexus around common carotid, then around internal carotid, then internal carotid will hand over some of its fibers here to the ophthalmic, from ophthalmic will go to the nasociliary, from nasociliary, now they are leaving and entering into the eyeball. When they will entering into the eyeball, you can say entering into the eyeball means they have to leave the nasociliary. Nasociliary has been now left, and these fibers are entering into the eyeball. Entering into the eyeball means more nerves are required, another nerve is required which will carry them. This time, because no nerve is going into the eyeball, that's why you have to make your own nerves. This time you know that autonomic nervous system, when there is no other nerve or artery to carry them, then they have to form their own nerve now. That's why from here the fiber's name will become, because they are here. So you see, when you pick up this fiber group which is making its own nerve, this is postganglionic. So where the cell body is lying? The cell body is lying here in the superior cervical ganglion. So such fibers will be short or long? These are long. That's why these nerves are called long ciliary nerves. We will show you short ciliary nerves also, but short ciliary are parasympathetic. This is called the long ciliary nerves. So your dilator pupillae is supplied here by long ciliary nerves, which contains postganglionic sympathetic fibers, whose cell body is lying in the superior cervical ganglion. But how they can reach there? They can reach, already we told you this, common carotid, internal carotid, through cavernous sinus, handed over to the ophthalmic, ophthalmic to the nasociliary, nasociliary to the long ciliary, and long ciliary enters to the sclera of the eyeball and will reach the fibers that are called the dilator pupillae fibers here. Not just dilator pupillae, but these ophthalmic nerve which I have actually told you, not just the ophthalmic nerve will actually pick up these fibers. Some of these fibers, in fact 1 or 2%, will be handed over to your third nerve also. You say, sir, why third nerve? You know that in the eyeball we have got actually in the range of the eyeball, in the eyeball inside is a dilator pupillae, but if you remember there was levator palpebris superior, almost 5% portion that was a smooth, and that smooth was also lifting extra eyelid, extra little 5 to 10% extra pull of the eyelid here. This is emotional. This is related to the emotions. This is related here to the fear or horror or anything like this. Means in emergency again. So that is the muscle that is called the molar muscle. And that molar muscle has to be supplied here by the autonomic fibers also. But which autonomic? Sympathetic autonomic. Oculomotor was not having sympathetic fibers, postganglionic sympathetic fibers. So oculomotor has to actually carry some of the fibers again from where? Well, the best thing is when it was running in the lateral wall of cavernous sinus is the highest area, it was actually looking at the internal carotid artery, which is having a huge bunch of postganglionic sympathetic fibers around its surface. So pick up 1 or 2% fibers here. You see the oculomotor is already having parasympathetic fibers, no problem. You will actually put these sympathetic fibers also along with them. If we are putting the sympathetic fibers along with them, you will see that sympathetic fibers will running along with them. And when the autonomic, this oculomotor nerve, when it enters into the superior orbital fissure, just before superior orbital fissure, it splits up into the 2 branches here. Superior branch, inferior branch, superior division, inferior division. They both enter separately, just like your ophthalmic, which enters into the superior orbital fissure separately via its 3 branches here: lacrimal, frontal, nasociliary. This time superior division, inferior division of the oculomotor. Parasympathetic fibers will go along with the inferior division, sympathetic will go along with the superior division. And when they will go along with the superior division will make here 2 branches. The 2 branches out of this, the 1 branch that will go up here, that will supply superior rectus and medial rectus, and one will actually be going here to the the branch that is actually going here to your levator palpebrae superioris also. These are the voluntary fibers, we know that. These are voluntary fibers. The 1 branch which is going up here, because 2 branches are there. So superior division will have 2 branches, the up and this lower. The lower will supply your medial rectus and the upper will supply superior rectus and levator palpebrae superioris. So your sympathetic fibers will go with the upper branch, and with the upper branch will split up into 2 branches. I told you that 1 to LPS and 1 to superior rectus for voluntary purpose. So these fibers which are postganglionic sympathetic fibers, which the oculomotor has actually inherited during its passage in the lateral wall cavernous sinus from internal carotid artery, they will be actually be running here with the superior branch, and the superior branch, that branch which is going into the levator palpebrae superioris. So voluntary fibers of oculomotor's personal fibers to the levator palpebrae superioris skeletal portion, and these fibers which it has inherited at its middle course from the internal carotid artery, they will go here to the Muller's muscle. And with the Muller's muscle, sympathetic will be stimulated. You see your upper eyelid will be lifted 5% extra, plus your pupil will be dilated here. This happens in the emergency. So these 2 muscles will be actually supplying like this here. Your sympathetic system through your ophthalmic and oculomotor is distributed to these 2 muscles this way, through when they were passing through the lateral wall of cavernous sinus. Now in this area, you have watched your sympathetic fibers, you have watched your 3 branches coming from your ophthalmic nerve here. Now this ophthalmic nerve, which I am actually telling you, this ophthalmic nerve, okay, it is present there, but during its course ophthalmic has given the 3 terminal branches also. But what will be the distribution of these 3 terminal branches? Whether these only 3 terminal branches, or before division into 3 terminal branches it will give some other also, just before, just proximal to the 3 terminal branches. Your ophthalmic nerve is giving here a branch that is called the recurrent branch. This is the recurrent branch, you can say, that turns back here. That turns back will go here to the posterior cranial fossa, and there is here a fold of the dura mater to which it will supply. That fold of the dura mater is called tentorium cerebelli. That's why this branch name is the recurrent tentorial nerve. This is called the recurrent tentorial nerve. So that means the first branch that has been given just before even termination into the 3 branches, that is called the recurrent tentorial nerve. This is recurrent tentorial nerve. This is the first branch. Then it enters into the superior orbital fissure in form of 3 branches here: lateral, lacrimal, middle, frontal, and then most medial will be the nasociliary, which is the larger branch. And here if it is entering now, so these all 3 branches will enter into the orbit. Now you are sitting in the orbit. In the orbit now you are watching these things. This is now a superior orbital fissure. This one is the inferior orbital fissure. This you know that this is the optic canal. And this blue color which I am actually showing you here, this is the common tendinous ring. If you remember, this is common tendinous ring here. This is common tendinous ring, which is in fact hiding the optic canal as well as the lower part of superior orbital fissure. If any structure will pass through the optic canal or the lower part of the superior orbital fissure, has to cross the tendinous ring to come outside in the orbit. When I told you that here lacrimal nerve and the frontal nerve, they are entering here into the lateral part of the superior orbital fissure, so they both of them will not cross the tendinous ring. So this is now your nerve, that is called the lacrimal in the upper part of the superior orbital fissure, and now this is the frontal nerve that is entering into the next part of your upper part of your superior orbital fissure, but in the middle part, but not passing through the tendinous ring, because tendinous ring will be hiding the lower part of your superior orbital fissure. So the third nerve, that is actually called the nasociliary nerve, it was so medial that it will actually enter into the lower part of the superior orbital fissure, so it has to cross the tendinous ring. If it is cross the tendinous ring, so that means it has to pierce the tendinous ring here, that is why it is piercing. So you can say this will be actually your nasociliary here. This is third one, this was your frontal, second, and this is your lacrimal. So these are the three nerves, these are the three terminal branches which are entering the superior orbital fissure separately. And one that is called the nasociliary, it will be very close here to the medial wall, that's why it is actually entering into the tendinous ring, common tendinous ring. And this common tendinous ring, we have already told you, it is actually giving origin to, this is not just the thickening of the periosteum, this is giving origin to the four rectus muscles, four extraocular muscles with the name of rectus. Superior, this is called here the superior oblique, you know that this is called the medial oblique, this is the inferior, medial rectus, this is superior rectus, I am sorry, not oblique, this is called the superior rectus, medial rectus, inferior rectus, and this is called the lateral rectus. Four muscles are emerging here, and two obliques are there, oblique from the one from the floor of the orbit, one from the roof of the orbit. These are the ciliary, these are the muscles, these are called the oblique muscles. Together these are the six extraocular muscles, and one muscle which is the levator palpebris superior is the skeletal portion. These all muscles are supplied here by these three nerves. The nerve number 3 is called the oculomotor, nerve number 4 is called the trochlear, nerve number 6 that is called the abducent. So you are watching these three nerves which have entered into the orbit now. Now when they enter into the orbit, you look at this nerve that is called the lacrimal. See this distribution of the lacrimal nerve. Now lacrimal nerve which is entering here into the lateral wall of your lateral part of your orbit now. When it's going here lateral side here, you see under this under the lateral part of your orbit, under the lateral part of your roof of the orbit, there is a groove that is called the lacrimal fossa. There is a depression that is called lacrimal fossa, where is lying a gland that is called the lacrimal gland. So this lacrimal nerve which is going towards the lacrimal gland, it is actually supplying some branches will enter into the lacrimal gland, and some branches will pass through the lacrimal gland, and some branches will enter into the lacrimal gland to supply them, and some branches will pass through the lacrimal gland and will come out of the conjunctiva and will supply here the conjunctiva as well as the lateral part of the skin of your upper eyelid here. So you can say it is a cow coming here. Now see, this is here, it's actually coming. See this lateral wall of your lateral part of your upper eyelid, and this is in fact supplying here little part of, you see the lateral part of your upper eyelid. This is called lacrimal nerve. So the conjunctiva on the lateral side, palpebral conjunctiva, even your bulbar conjunctiva, gland, and all these things have been actually supplying here. It was not just it is supplying these things. A very, very important thing will be that most lately when it is reaching here, passing through the lacrimal gland, it is giving two anastomotic or communicating branches outside, which will join with one of the branches coming from the maxillary nerve. One of the branches coming from the maxillary nerve, which branch? In the body of the zygomatic bone, there were two foramina. One is called close to face, that is called the zygomaticofacial, and another is called the zygomaticotemporal foramen. So from zygomaticotemporal foramen, one of the branches of the maxillary will actually come out here. That is called the zygomaticotemporal. That will go here to the temple, but two communicating branches from the lacrimal nerve will join the zygomatico-temporal nerve. Communicating branches here, anastomotic branches here. We're joining the zygomatico-temporal nerve. And if any time, which will happen surely, if any time the zygomatico-temporal nerve carries the postganglionic parasympathetic fibers, so now zygomatico-temporal nerve can through these anastomotic branches send the postganglionic parasympathetic fibers, last terminal parts through these anastomotic branches over the lacrimal part into the lacrimal gland. Means the last part of the parasympathetic postganglionic fibers to the lacrimal gland, which was running on the lacrimal nerve, and second last on the zygomatico-temporal. Before that on the zygomatic, even before that maxillary. So your lacrimal glands in fact are supplied like this here. So anastomotic branches from here, lacrimal is important from this point of view also. After that you see here there is another branch that is called the frontal branch, and frontal branch which will be present here in the close to the roof, you see that, and a frontal branch will split up into two branches here. One is called the supraorbital, one is called the supratrochlear. Supraorbital will turn around your supraorbital notch, which is here at the middle of your superior orbital margin, and that comes onto your forehead, will reach up to the scalp here. So all the skin of the scalp up to the vertex, then the forehead here, the little lateral part or the middle part of your forehead, and even your upper eyelid, the central portion, even the conjunctiva, everything will be supplied here by supraorbital nerve. So on the face it will come like this. You see, this is called the supraorbital nerve. The supraorbital nerve is there. This is one of the branches coming from frontal. But the second terminal branch of the supraorbital is called supratrochlear. You see supratrochlear. Why called supratrochlear? Because on the medial wall of the orbit, close here to the lacrimal gland, there was a pulley, and pulley is called the trochlea, and this is the trochlea through which the tendon of superior oblique muscle was passing. So above that was actually present here one of the terminal branches of the frontal, that is called supratrochlear. The supratrochlear reaches here and will come out of the medial canthus here, will supply here the medial part of your eyelid here, and will goes here onto the middle portion of your forehead here. This is called supratrochlear. With this now you are doing some part of your even the ophthalmic contribution of your cutaneous innervation of your face also. This is called the supratrochlear. These are the two branches of the frontal. But after this, now we come to the nasociliary. And if you look at the nasociliary, now you watch it here. This was your ganglion, trigeminal. This is now your nerve, that is called the ophthalmic nerve, which was giving certain branches, like see the branches, which one? Say this is the lacrimal, this was a frontal. Now this is the branch which we are discussing here. This is called nasociliary. And nasociliary, you know that it is giving some branches which pass through the ciliary ganglion also, and some branches will go enter without passing through the ganglion into the sclera, long ciliary. But whatever nerve itself is having the fibers here, these fibers now are running along the medial wall, and when along the medial wall they will look at the medial wall. There are two foramina in the ethmoid bone, one which comes earlier, the one that will come later. The one which comes earlier, that is called the posterior ethmoidal foramen. You see this red color which I am showing you here is called the posterior ethmoidal foramen, and here one of the branches on that side it will be given here through this foramen, that is called the posterior ethmoidal foramen. This is called the posterior ethmoidal nerve, a branch of nasociliary. After nasociliary, immediately has given the communicating branches to the ciliary ganglion and the long branches into the sclera, this is called the long ciliary nerves. But this time posterior ethmoidal also, and posterior ethmoidal will enter here into medial wall of your orbit to enter into the ethmoidal air sinus, will supply them, and then it will actually go upward here, or you can say upward means they are passing through the cribriform plate here, and they are running on the cribriform plate, and one of the foramina, when it will actually be going, then it comes here into the nasal cavity to supply a part of the nasal cavity also. This is called the posterior ethmoidal nerve. It is forming, you see, supplying the ethmoidal and as well as your sphenoidal sinus, and it will come here into the nasal cavity. So it is supplying here the nasal cavity also. But you know that when this Nasociliary nerve is running more anteriorly. Last time you see that foramen will come, that is called the anterior ethmoidal foramen. Right at the anterior ethmoidal foramen, it will split up into two terminal branches. One that will enter into the anterior ethmoidal foramen, that is called the anterior ethmoidal nerve, and the one which is actually continuously coming out of your orbit to come under the face, that will be actually called infratrochlear nerve. So this last one is called the infratrochlear nerve. And this one which has entered into the anterior ethmoidal foramen has gone into the ethmoidal air sinuses and will penetrate to come here and to supply even some part of the mucosa of nasal cavity also. This is called a anterior ethmoidal nerve. One of the terminal branches coming from nasociliary. And the second terminal branch is the infratrochlear nerve here. So that means when you are actually looking at your face here, the part of the forehead, entire upper eyelid, and even the side of the nose as well as up to the tip of the nose, all this area actually is even the scalp also up to the vertex, not beyond the vertex is by your spinal nerves. All these things in fact will be supplied here as far as your scalp and the face is concerned by the ophthalmic nerve. So ophthalmic nerve division is, so that means through the ophthalmic nerve you have in fact supplies the conjunctiva of your upper eyelid etc. here. Through that you have actually supplied here the cutaneous innervation to your face as well as the scalp, forehead etc. up to the nose, even the tip of the nose also. And all these things you have to see here in these things, and during this whole process you have seen certain sympathetic and parasympathetic fibers running on various parts of your nerves also. This is something that you have actually seen here in the ophthalmic division of the trigeminal nerve here. Now, after the ophthalmic division of the trigeminal nerve, we will bring here another nerve of the trigeminal, that is called maxillary division of the trigeminal nerve. For this purpose, again the cranial cavity is important, cavernous sinus is important, exit point rotundum foramen is important, but beyond the rotundum foramen, the environment is different. This time is not orbit, this time you know that in the base of the skull is lying the pterygopalatine ganglion. I say pterygopalatine fossa. Pterygopalatine fossa will be important. You have to see its anatomy, and from pterygopalatine fossa you have seen a lot of communications here from the floor, from medial wall, anteriorly, posteriorly, and outside here laterally also through pterygomaxillary fissure. All this anatomy will in fact be employed again. This we will actually do after a short while.